So HIPEC has been something that people have been particularly interested in. This, again, stands for heated intraperitoneal extracorporeal chemotherapy. We talked a little bit before about the standard IP chemotherapy, which is essentially some of the chemo is given IV and some is given intraperitoneally. This is what you can see in this is that HIPEC is done as part of a surgical procedure. And so you can see this patient who has a midline incision and then has several catheters going in where the heated chemotherapy is being circulated. And that actually goes on for a couple of hours in the use of this approach. So you can see it's a pretty intensive approach. Lots of interest were sparked by this publication that looked at hyperthermic intraperitoneal chemotherapy in patients who had had neoadjuvant chemotherapy and were undergoing interval debulking. And basically, it was they're having their surgery when they're halfway through their chemotherapy, and they were randomized to either get HIPEC or none with that surgery. There was a lower recurrence rate ultimately for patients who got the HIPEC and improved overall survival. But people have said, well, is this due to the HIPEC or, you know, they're getting basically an extra course of chemotherapy. Maybe if we gave just another course of IV chemotherapy, people would do better. Or is there something about heating the peritoneal cavity that's changing the immune modifiers or something like that? So there's lots of questions about whether or not it's really the HIPEC that does this or not. And part of the reason for this question is because there was another another study that was presented that looked at exactly the same thing with the initial surgery for ovarian cancer, so people who are undergoing primary debulking surgery. And this used either HIPEC or no HIPEC, and there was an increased risk of some toxicities, including anemia and increased creatinine in the HIPEC group, but there was no difference in the recurrence rate or survival between these two. So, you know, people have been, again, scratching their heads. Why would HIPEC work when you use it partway through chemotherapy but not at the beginning? So how can we, how can we make decisions about this? And so, you know, there are plans to do larger studies that will hopefully answer some of those questions about HIPEC. So our summary for initial treatment, we do surgery and attempt at maximal surgical cytoreduction. Neoadjuvant chemotherapy before surgery is an option for patients who we don't think are going to be able to have good surgery. Chemotherapy, usually 6 cycles of a taxane platinum combination is standard. We can give intraperitoneal chemotherapy in patients with low-volume disease, but it does have increased toxicities. Paclitaxel and docetaxel are equally effective in combination with carboplatin. The weekly dose-dense paclitaxel can improve outcome. In some studies, confirmatory studies have not all showed the same outcomes. There's no current role for a third chemo agent. Bevacizumab during and after chemotherapy improves the recurrence rate but not overall survival, and we'll go into that a little bit in more detail. And HIPEC may be beneficial after neoadjuvant chemotherapy.